Wonderful. Okay, so as Jane said there, my name's Guy Bradburn. I'm the ward manager on the renal transplant unit at the Manchester Royal Infirmary. So first and foremost, thank you for having me today. Thank you for letting me speak, Jane. And I just wanted to give a very, very brief overview of myself, if that's all right first. So I started in renal transplant back in 2011 as a newly qualified staff nurse. Entered the world of transplant quite by accident, didn't have any transplant experience through my training, and then just landed on the transplant unit, as I say, as a newly qualified band 5. Did a few years in that post and then moved on to a band 6 role, which is the equivalent of a junior sister. I then moved briefly into a team with Malcolm and the transplant coordinators, and then I actually took the job as the ward manager of the transplant unit back last January. So as you can imagine, been quite an eventful 14 months, feels more like 14 years, I can assure you. So when I was first asked to speak about the ward and the ward experience for our patients, the first thing that came to my mind is what makes up a ward. Now for me, a ward is where I go every morning, or certainly Monday to Friday, 7 o'clock on the dot. And it's where my office sits and where all our wonderful patients are. But the ward itself actually is made up of a huge number of people, and the ward that you see, as patients, consists of lots and lots of different specialists and teams. So I wanted to highlight those really. So there's what I consider my team, which is the nursing team. They're made up of various different grades of nurses, clinical support workers. There's a relatively new role called a nursing associate and a trainee nurse associate, qualified nurses, and so we have 2 junior sisters on our unit at the moment, and myself as a ward manager. We have the transplant surgical team, of which Hussein, who you've met virtually this morning, is part of. We have 10 consultants, surgeons, and numerous registrars. We have the transplant nephrology team, the kidney doctors. We have a domestic team, so housekeeper, cleaning staff, food service team, junior doctors, which are on a rotational basis. The pharmacy team, which consists of obviously ward pharmacists with specialist interest in renal, pharmacy techs, the transplant coordinator team, and obviously an admin team. So we're made up of quite a large team that sometimes needs some managing and some dealing with. Well, that's who you'll meet while you're on your various transplant units. So obviously, I wanted to take up the presentation from the point just after Malcolm, really. So essentially, at this point, Malcolm has, or Malcolm and his team, or the various transplant coordinators around the UK, have given you taken an offer, accepted the offer, and given you a call to check that all's well and that you're keen to come into us. So at that point then, the transplant coordinator team will get in touch with the nurse in charge on the unit, whether that be myself or one of the juniors. Now, Monday to Friday, 8 till 4, their office is just off our ward. So that it's usually they'll bob round and have a chat with us. But then out of hours, obviously we're contactable by phone, and we have these mobile phones around our neck so they can get us wherever we are. At that point, they'll give us the information, they'll give us the donor number of which they've accepted an organ from. They'll give us the intended recipient and some details on you so that we can find you in the transplant waiting list and on our computer systems. And they'll tell us what time that you plan to arrive with us. Now, when you arrive to the ward, unfortunately at the moment, because of obviously COVID-19 and the lockdown, we are not accepting visitors onto the unit at all at the moment. Now, obviously this has been particularly tough, both for us and for the patients. For us, it's always nice to have, a family member there to give you even more support than we can offer, but unfortunately, at the moment, that's not happening. So when you arrive, all of our patients are going into individual rooms because obviously you've come from home and we don't know your COVID status, we don't know anything like that. So we pop you into your own room. The room will have access for dialysis if required, and all the necessary things we need. So you'll be screened first and foremost with a very brief interview, as in temperature, any new symptoms of COVID, which will have all been gone through with Malcolm as well. And then we do a COVID swab. As obviously transplantation is time specific and time orientated, we have access to rapid COVID swabs, which take about 4 hours to come back, as opposed to the national screening program, which takes anywhere from 24 to 48 hours. So our swabs take about 4 hours to come back. We'll do your observations, your blood pressure, your temperature, your heart rate, your oxygen levels. We do account for the fact that you're probably quite stressed, perhaps haven't taken your medication, depending on the time of day, and therefore your blood pressure might be all over the show. We do take all that into account at that stage. You'll have blood tests, which I'm sure lots of people have talked about. This is essentially a full MOT of blood tests, and obviously the stuff for the transplant lab as well. We take some more swabs for MRSA and CPE, which is obviously hospital-acquired infections or hospital bugs. You'll have an ECG, which I'm sure most of you are familiar with. It's an electronic trace of your heart. A chest X-ray. You'll be admitted by one of the nurses who'll do all your risk assessments and admission. You'll be seen by one of the surgical team, and they'll come and talk you through what the plans are. They usually have more up-to-date timings than the nursing staff have access to. You'll have a medical review from one of the nephrology team if required, with regards to your physiological state and whether dialysis is necessary. Occasionally we do facilitate dialysis preoperatively, just so that you're optimised when you're going into theatre, from a fluid point of view and potentially from a blood result point of view, making sure you're safe for anaesthetic. Now, the pre-op period, unfortunately, as probably Malcolm's gone into, there are numerous reasons why timings change for transplantation, whether that be the need for cross-matching in the transplant lab, delays at the donation centre, even delays such as traffic on the road when we're transporting the organs around the UK, can all play a part in the timings of your transplant. Now, we obviously for some period of that you'll be nil by mouth in order to make sure it's safe to put you off to sleep. So what we currently work on is a minimum of 6 hours for food and a minimum of 2 hours for water. Now, when we say water, that is unfortunately just water, not a cup of tea. Milk is classed as a food item in this case. For our elective patients, for those having a live donor transplant, as opposed to a deceased donor transplant, we have the pre-op drinks that you can see on the screen there. They can be taken along with water up to 2 hours before. They're a carbohydrate-based drink that is designed to aid recovery post-operatively. For some of you, you may well be on blood thinning drugs such as warfarin or apixaban or things like that. And in that case, we may need to reverse the effects of that to make it safe for your surgery. That'll all be done on the ward prior to going to theatre. And obviously they're everyone's favourite hospital attire, the backless gown and stockings, is all standard stuff. Now, one thing that we often get asked about, more so from relatives and from your loved ones, is your theatre times. Now, unfortunately, I missed Hussein's presentation earlier on. I don't know if you went into theatre times, but essentially often what you'll find is when you go to your transplant assessment appointments or when you have them virtually, however your hospital's working, the surgeon will say, oh, your operation will take about 2.5 hours. Which is great because we all know that the surgeons are the most important people, and once their bit's done and dusted, they're off home. But actually that forms, part of a much larger process. So your time in the anaesthetic room actually can be anywhere from an hour to 90 minutes while they get you off to sleep safely, get all your lines in and your monitoring on. Your Theatre time, the surgeons are right on that one. It's about 2.5 to 3 hours for a kidney transplant, all being well. I've just put briefly on there about an SPK, which is a simultaneous pancreas and kidney transplant. Now, I know that in PKD, not many people have SPKs, but occasionally that will happen. That'll be for patients with diabetes as well, insulin-dependent diabetes and kidney failure. They take a good bit longer, some 5 to 6 hours. You'll then be in recovery from anywhere between 1 to 2 hours, and then you'll be transferred back to the ward or to critical care. Patients that have had an SPK, a pancreas transplant, will always go to critical care post-operatively. So actually, the point I was getting back to is the surgeons say you'll be 2.5 to 3 hours, and your family members are on the phone to us at, exactly 2 hours and 31 minutes, rightly so, asking where you are. But actually, I always say from the moment you leave the ward to getting back to the ward is around about 6 hours for a kidney transplant, and that's what we tend to work on, and that's what we tell your loved ones. And we will always call your friends, relatives, whoever you want us to call when you're back on the ward to let them know that you're safe with us. Now, post-operatively, for a large majority of patients, it wouldn't be their first time in hospital having a transplant, unfortunately. I know that, along with the condition comes, unfortunately, various trips to hospitals and various units. But when you do wake up, there can be lots of unfamiliar beeps and noises and lots of tubes coming out of places you never thought they'd be able to put tubes. So I just wanted to put a few examples on the screen there so that you can see exactly what might be going on. So there's various pumps. The one in the top left of the screen is what we call a PCA. That's patient-controlled analgesia. That will be your best friend for the first 48 hours post-op. You press that button and it gives you some opiate. Various centres use different opiate-based pain relief, but that's what that one's for. The one in the middle at the top, that's the monitor. That's the important one for the nurses. That tells us all of your vital signs, your heart rate, your blood pressure, your central venous pressure, and various other things that we need to know about. And then, as I say, we've got different pumps for different infusions, a catheter, which unfortunately is a necessity post-transplant, and obviously some oxygen there just while you come round as well. Rest assured, all the nurses will be more than capable of dealing with all the various tubes, and all we ask you to do is worry about recovering and not worry about all the tubes. They're our job to look after. And as I say, sometimes it does look a bit like Spaghetti Junction, but I can assure you we know where they're all going and what they're all doing. We couldn't possibly talk in 2021 without discussing COVID-19 in depth and the hospital. So I just wanted to discuss very briefly, well, not very briefly, I wanted to discuss it to let you know what we're doing as best as we can to keep you all safe when you come to hospital. So currently in Manchester, and I suspect it's the same elsewhere in other units, we have staff screening in place. So anyone that you come into contact with on my ward certainly will have been screened weekly. This is not we don't use the lateral flow testing that a lot of places are using. We're doing exactly the same swabs as our patients are having. We get to go through that once a week for our pleasure. So that's a nose and throat swab every single week. And obviously, if any of those were to come back positive, then we would be off-site, self-isolating. We have a couple of occasions last year, actually, where that did happen, and 2 this year. But obviously, it is kind of a proactive approach rather than reactive, waiting for people to get symptoms. Patient screening, unfortunately, you don't miss out. As I said, we will screen you on day as you arrive on what we call day 0. You'll have your 4-hour swab then in order to see if you're able to proceed to transplant. Unfortunately, if that comes back positive, there isn't an option to be transplanted on that day. That'll be discussed with you. We have, unfortunately, since the restart of the program back in July, we've had 2 patients that have come into the hospital, totally asymptomatic, with no known contact with anyone with COVID, that have tested positive on their swabs, but only 2. And as Malcolm said, we've done 153 transplants, so it is positive. The shielding that you guys are clearly doing is working well. and it's clearly been worth it for the large part. We also screen all of our patients on day 3 post-op, day 5 and day 7. That's if you're still with us at 7 days, and after that it's weekly. I can say, and please all of you, touch wood at home wherever you may be, we've actually as a unit had no hospital acquired COVID infections. I think we're one of the only wards, certainly in the Manchester Royal Infirmary, that haven't had a single hospital acquired COVID infection, so long may that continue. As I said, currently there are no visitors allowed on the unit because of the kind of screening, really. As I say, we're screening staff, we're screening patients, we're doing everything we can to make sure people aren't coming on with COVID. So we just can't possibly allow visitors at the moment. We do have an iPad on the ward that is available for virtual visiting, much like you have your virtual appointments. It's a similar computer system where we send out a link via a text message to people. And actually, we have used that a fair amount, but more often than not in this day and age, people tend to have their own iPhones, smartphones, and they tend to be doing it themselves a lot of the time, but that is available for those that don't. We're minimising time for any of our patients going off the ward. All scans and x-rays are A, done on the ward where possible, and B, scrutinised to see if they're absolutely necessary, because every time you go off the ward, there is that risk that you may come into contact with someone in a lift, on the corridor. For that reason, we obviously give face masks out for all patients that are coming out of the room or the bed space. On our, as I say, I can only speak unfortunately from Manchester's point of view, we have a 22 bedded unit at the moment, which has 4 bays of 4 beds and 6 side rooms. We're only currently opening to a capacity of 12 in order to socially distance those spaces. So in each of the 4 bedded bays, we've got a maximum of 2 patients on a diagonal from each other. So actually they're about 4 or 5 meters apart. And then, as I say, we have the 6 individual rooms where we're trying to keep people where possible. Our theatres are doing their bit too. They have dedicated theatres that are only for what we call green patients. The hospitals nationally have all gone into a system where we have green, blue and amber areas. Blue being COVID, amber obviously being undecided at that stage, and green being COVID negative. So we have specific green theatres, we have specific green lifts and routes that all the porters know, and as I say, it's all done to try and minimise the risk. I think that Liz probably touched on this earlier, something called ERAS, which is stands for Enhanced Recovery After Surgery. This was a programme that was partially developed in Manchester, originally for elective surgical patients, usually for cancer surgeries. But when we paused the programme last year and looked to relaunch back in July, we looked at how we could implement ERAS to reduce length of stay for our patients and reduce post-operative complications, which is essentially what the programme was designed to do originally. In its original trial and in its original implications, it reduced average length of stay by 3 days for those patients and reduced respiratory complications by 50%. So that was our aim, really, in order to keep patients as safe as possible. So we launched, so we developed, myself, Hussein, and a couple of colleagues developed an ERAS program, which is on the next slide. We actually had been talking about putting it in place for a long time prior to this, and then this gave us the perfect opportunity to use it. So you can see that's what we aim for all of our patients receiving a kidney transplant, whether that be a live donor kidney transplant or a deceased donor kidney transplant. You'll see in the top right corner there, obviously patient demographics, and then we put your dry weight in, or your target weight, and then we work out what your dry weight is plus 3%. That's for us to do. Now, this is historically, post-operatively, you have an awful lot of intravenous and oral fluids. in order to try and hydrate the kidney as much as possible in its first 48 hours. And that often left the patients being overloaded for a few days post-operatively, which slowed everything down with regards to the recovery. It slowed down wound healing, gut motility, mobility of walking around. And so we worked out that 3% would be a reasonable amount for people to gain, and not stop them, recovering properly. So on day 0, which is the day of your surgery, we hope that people will be feeling up to eating and drinking in the evening of their surgery if it's gone ahead in the morning. Pain control is via a PCA as discussed. Regular laxatives in order to start that process. And we give something called output plus 30. Now that is based around your urine output and how much urine you pass. And we give you intravenous fluids to match that plus 30 mils. For example, if you passed 100 mils in an hour, we would give you 130 mils of IV fluids the following hour to compensate for that. You'll be weighed on day 1 the following day, and if your pain is reasonably well controlled, we'll look to stop that PCA. And that's purely in order to allow you to mobilise a bit better, just because we're going to ask you to get out of bed, be weighed and sit in the chair. We will do our absolute utmost to support you with this. Fortunately, this is one of the points where people look at us like we've got 3 heads. They're just ready for their morning nap and we come to get them out of bed. But I can assure you it's all research driven and it's not sadistic by the nurses. We're checking your drains each day. We're checking all of these things, and you'll be reviewed by our pharmacist as well, because there's a number of medications that are safe for you to be on dialysis and with kidney disease. But once you've had a kidney transplant, we look to stop a lot of those. And obviously, I think you've got a pharmacist talking to you shortly about that. On day 2, we'll look to stop your IV fluids totally, unless we've reached your weight prior to that, your dry weight plus 3. And we aim to get you to walk 10 metres. We normally ask you to walk to a bathroom so you can have a wash, brush your teeth, generally freshen up and walk back. As I say, we're not expecting you to do any of this on your own. We're there to help you through all of this. You'll also have a central line put in while you're in theatre, and we look to remove that on day 2. We'll change your dressing, inspect your wound, and we'll ask you to drink fluids. Day 3 is usually quite an eventful day. We usually look to take your catheter out and hopefully get you passing urine by yourself. We'll look to be taking your drain out by day 3, and we'll definitely want you to be starting to move your bowels. So unfortunately, it's an enema if required to get your bowels going. Now, none of these are compulsory. They're all with a discussion with you, and we give you the information you need to kind of decide if you think it's the right thing to do. We look to take out dialysis lines at this stage if you've got any lines in place, such as Tessio lines or VAS caths. Now, this is purely because by day 3, we'd like to have a good idea of if this kidney's having a sleep or if it's working straight away. We aim also to get you to walk about 20 metres, which fortunately our corridor is about 10 metres. So it's up and down the corridor on day 3. Again, we'll give you a face mask at that stage. Day 4, we give you a drug called Simulect, which is a strong immunosuppressant drug intravenously. You have 1 dose of that while you're in theatre and you're asleep. You know nothing about that one. And we give you day 4. Now, we are also aiming for our patients that are doing particularly well to be going home on day 4. I would say at the moment, we're achieving that in about 50% of our patients, more so in those receiving a live donor transplant, because we haven't got the necessary worry that the kidney is going to go to sleep like we do in deceased donor transplantation. So as I say, about 50% of our patients are going home at day 4, and then they're coming back to clinic 48 hours after that. So your recovery. So as I say, the main thing that we look for in the early stages is your blood results. Now, a lot of you with polycystic kidney disease will continue to pass urine right up until the transplant. Patients that suffer from other kidney diseases may not do that. So urine and fluid monitoring is excellent, but unfortunately we have no way to tell whether the urine is coming from your transplanted kidney or your own native kidneys. And so urine monitoring, whilst important, is not the be all and end all for you guys. Blood results are. So you'll have bloods, as I've put there, daily, and that's as a minimum. On your day of transplant, you'll have at least 2 lots of bloods about 4 hours apart, just to check that all of your bloods are safe. And the first thing that we tend to look at is your creatinine, which is obviously one of the waste products in the blood. We don't tend to use EGFR as a tool, and I know that whilst you're a nephrology patient, or what we call a nephrology patient leading up to transplantation, EGFR tends to be what everything's based around, whether you're looking at dialysis options, transplant options, and where you're up to in your kidney disease is based around GFR. In the first 6 weeks post-transplant, GFR is not a great measure because the kidney's not settled, it's not working at its optimum, and we've still got lots of tweaks to do at that stage. So we look at creatinine, and essentially as long as your creatinine is coming down, we're happy people. You'll be weighed each day. The surgeons and the medical team do a ward round together each day, so you'll be seen by a nephrologist and a transplant surgeon on a daily basis. And the pharmacist also do a daily review just to check that your medication is all optimized. So I've put there maybe dialysis. Some people are often scared and shocked when we give them some dialysis post-operatively. They believe that they've had a transplant and they shouldn't need it. As some other presentations may have alluded to, and I have as well, kidneys can go to sleep when we transplant them. They've been taken from the donor, packed in ice, transported around the UK and retransplanted. They sometimes decide that they're going to have a bit of a paddy and not work for a few days. And therefore, just to maintain safe blood results and safe fluid levels for you, we sometimes give you some dialysis. This is probably, again, in about 50% of our patients will have dialysis post-operatively. I've put pain there because, unfortunately, it's as a ward manager, it's one of the things that I hear most when I go around and talk to the patients about how things are. Unfortunately, surgery, they do have to cut through your skin. It is going to be sore. We do our absolute utmost to make sure your pain relief is optimized for you, that you have all the necessary medication and pain relief that we can give you. But I always put it down there as an expectation. You will have some, unfortunately. It will be short-lived as best as possible. And I've also put their diabetes team input. Some people also get slightly worried when the diabetes team come to review you and you haven't got diabetes, and you think, God, what have they done to me? Now, some of the medications that we give post-transplant can cause erratic blood sugars in the first few days. And so the diabetes team are just there to make sure we don't need to give anything to counteract them, and just to make sure that your blood sugars aren't going to have any detriment to your recovery. Length of stay. So length of stay is very variable for each person. If I've put on there deceased donor kidney transplant 4 to 10 days. So if your transplant goes well, your kidney works straight away and you recover from surgery as we would expect you to do on a nice smooth path. And as I'm sure you all know, kidney disease and hospitals, everything goes smoothly every time. There are never any hiccups in the road. So we would hope to get you home after 4 days if that is the case. Occasionally, as I say, patients can be with us up to 10 days. Live donor kidney transplants, we expect slightly less complications because they're planned elective cases, and we know a little bit more about what we're dealing with, and they're somewhere between 4 and 7 days. As I mentioned before, if you're coming in for a simultaneous pancreas and kidney transplant, generally speaking, you'll be with us at least 10 days, anywhere up to 3 weeks, depending on the number of factors. They are only a guide, all of these figures, and as I've put there, a bit of a cheesy line, we believe it's better to go home once rather than go home quickly. There's no point in us sending you home quickly and you needing to be readmitted with complications. Unfortunately, the way the transplant unit is running, certainly in Manchester at the moment, we've only got what we consider fresh transplants, so patients that have come in, been transplanted and are waiting to go home on the unit. We're not able to take readmissions at the moment. They're going to our renal medical unit. And so, as daft as it seems, some patients are home for 40, well, it's actually not happened, but occasionally patients may be home for 48 hours, come back in, and they're not able to come back onto the transplant unit at that stage because they may have been exposed to COVID. And obviously we've got such a limited number of beds at the moment. We're only open to 12 that we can't have readmissions. Discharge. So patients are always at discharge when they're able to complete their ADLs, which is activities of daily living with minimal support or independently, and your kidney function is improving or stable. In the first immediate post-op period, patients come to clinic twice weekly. Usually their first appointment is about 2 days following discharge. Certainly in Manchester clinic, our clinic team will complete all of your wound and line care. So we don't do any district nurse referrals for you, but just due to the frequency of your appointments, you're coming to us twice a week, which is usually absolutely plenty for your wound dressings and your line dressing changes. And because you're in and out and we're trying to minimise the people coming into your home, we don't really get the district nurses involved where we can help it. So that's all I had for my presentation. I'm more than happy to take a couple of questions if we've got time. I'm aware that people are probably wanting the lunch.
Yeah, Guy, thank you. Yeah, we're a little behind, but it's not your fault. We've been sort of running behind all day. I think, are you staying for the Q&A at the end?
What time are you planning to do the Q&A?
Well, we were planning on doing it at around 3:10.
Okay, I can do my very best to pop back on. I'll have to disappear in between, but yeah, I can.
Yeah, I'm just wondering, unless it's a real quickie, Susan. I'm just wondering whether.
I'm looking at the couple of questions there that are quite specific. Perhaps Guy would be kind enough even to type in answers to the couple. There's one regarding should you take your medication when you get the call, and another was small one about the dialysis needs. But I'm sure you can answer them personally or in the later session to try and get us back on time, because I think everyone's needing a cuppa.
Yeah, and probably a loo break, I imagine.
Yeah.
Well, that's fantastic. We were due to start our next session at well, actually now, but what we're going to do is we're going to take a quick break, come back on at 2 o'clock. Where we are going to hear from Sian Ellis. Sian, are you in the? Have you joined yet?
I'm here. Yeah.
Well, are you okay with that?
Absolutely. Yeah.
Yeah. Sorry, we're just a bit. But you know, these things happen.
No problem.
Delays occur when you're having fun, which transplant obviously is. Okay, fantastic, Guy. Thank you. We'll see if you can answer a couple of questions now in the Q&A, and we'll see you again later.
Yeah, of course. Thank you.
Audience, we'll see you soon. We'll see you at 2. Thank you.